Thank you all for coming tonight to participate in our forum on New York Health Care. My name is Eileen Riley. I'm the president of the League of Women Voters of Putnam County. We are a relatively new league that started in Putnam County in 2008. We are a not-for-profit, nonpartisan, grassroots political organization open to men and women. The League encourages informed and active participation in government, works to increase understanding of major public policy issues, and influences public policy through education. The League neither supports nor opposes any political party or candidate for elective office. Tonight, our League, in cooperation with the Mahopac Public Library, is hosting a discussion to educate all of us on New York Health Care for All. The League of Women Voters supports a single-payer system of health care. The hospitality table is located at the rear, if you haven't seen it yet, where coffee and snacks are provided, along with League brochures and information provided by our speakers on New York Health Care. The League donation jar is also at the back at the hospitality table, and we ask that you consider supporting the League by providing a donation. I'm very pleased to announce Lillian Jones, Chair of the League of Women Voters New York Health Care Committee. Lillian.
Thank you, Eileen. Just welcome everybody here tonight. I know, I'm sure that there'll be additional people coming and joining us as time goes on. If you haven't gotten a little packet of information that would be helpful for tonight's program, they're in the back, along with some personal story that might be very interesting for you guys to read. We thank you for joining us tonight, and what should be a very, very informative look into the future for New York healthcare. The League, as Eileen said, does have a position on healthcare. It's in our program, and it's been approved by our whole state. You know, the League doesn't get to just make decisions as to what policies we're going to support or not support in our local areas, so that there is a long position that's been well thought out. The program, I want to thank the program committee tonight for helping put this together. If you could stand, I'd appreciate it, just so we can acknowledge everybody. I'd also like to welcome a few special guests tonight. We do have Michael Weinberg, who's the special assistant to Senator Harcum, joining us tonight. The senator has a NARCOM training tonight and is not able to join us. I think this has been a very popular date for programs tonight. We're competing with all sorts of different things around the county. We're also going to be collecting your questions tonight. We do have a question and answer period after our speakers, and we will be collecting your questions, and Susan and Armando will be going, collating them so that we don't get repetitive. And if you have any, if you need any index cards, they're in the back, or Julie has them at the table up front. And if you need more of them, just raise your hand and one of the League members will come and help you with that. While I will be providing more detailed introductions of our speakers just before each of their presentations, I would like to thank Senator Rivera for being here tonight, Dr. Peter Artnow, and Katie Robbins for joining us tonight. And I want to start with the reminder that behind all the policy discussions that we're going to hear tonight are the personal stories of thousands of people who've had interactions with the healthcare system. And I'm sure many of you are part of that group that's had some interesting discussions with your providers and what kind of care you can get. People who are insured, who are underinsured, and those who don't have insurance are all affected by how our healthcare system works. Tonight we actually have two personal stories to share. One of them, the speaker, who's actually a very good friend of mine, is not able to join us tonight, but she was kind enough to write up her story, and we have it in the back. And what was very interesting with her is that she's a person who was in the healthcare system and helped people navigate the healthcare system for years. She is well insured, as are her relatives, who she's talking about in the story. It's actually her daughter-in-law, who was also very well insured. But if it hadn't been for this woman's ability to do the research needed on the prescription drug that was prescribed, and it hadn't been for her knowing a lot of important people, her daughter-in-law would not have gotten the prescription that she needed for health care. So this is something that affects everybody. We do have a story tonight from somebody who didn't have health insurance. And Dave Howell, who's our League of Women Voters member, will be talking for a few minutes about his personal story. Dave?
I'd first like to point out that I'm a member of the League of Women Voters, and I'm not a woman, so we don't discriminate. The Affordable Care Act was put into law in 2010, in March. I work as a horticulturist. Physical work is not lucrative, really, unless you own your own business or work as a designer or architect. So, you know, I got by, but I made a foolish mistake and didn't have health insurance. It was difficult to afford to have health insurance then for me. In 2011, spring, about a year after the Affordable Care Act was enacted, I had some symptoms, went to the doctor. I was diagnosed with testicular cancer. Was encouraged by my primary care doctor to go and have it addressed immediately. At the time, I had months, not many months prior, moved from Connecticut to New York. Was in a new relationship, and it was a little disconcerting not knowing quite what to do, and I had a wonderful support system. Went to see an oncologist. Surgery was scheduled, and then I was asked to go into the financial office at Putnam Hospital Center and asked if I had health insurance, and I said no. And was asked how will I pay for it, and I said I'm not really sure. They asked for a co-signer. My girlfriend, who just happens to be the president of our league, Eileen Riley, co-signed for me. There's a service, it's like a credit card, but it's in a short-term period. You pay back without interest, care credit, so I signed up for that in the financial office at the hospital. But they were not going to perform surgery on me unless they were assured that they would get paid. And so that was very difficult to deal with. The surgery was very successful. I was out of work recovering for 6 weeks, had no income during that time. Every 6 months I'd have to go for tests, blood work, and CAT scan, chest x-ray, and so on. And I was very fortunate not having to have any kind of radiology or chemotherapy. I've graduated to not having to go for tests and blood work. Now it's only once a year. So, I'm a fortunate, blessed person that I'm healthy and able to continue what I do. However, were it not for the Affordable Care Act, which does have its shortcomings, you know, if that were not available for me to get health insurance after the fact with a pre-existing condition, I have no idea where I'd be today or what kind of shape I'd be. So I personally feel very strongly that healthcare for all is something that really shouldn't require that much thought. We would all benefit. A lot of countries have that. Recently met some people who live in Sweden, and they're very happy with the services they get. It's very affordable to them. In this great country of ours, I can see no reason why we can't make it happen here. And that's my story.
Thank you very much for sharing that personal story. No, I'm reminded of there's a new center at Putnam Hospital for integrated breast health that the hospital offers a lot of services for women who are going through surgery, and they do a lot with meditation and massages before they go through surgery to relax them. Certainly the experience Dave had was not one that was relaxing. So we thank you for sharing that, and we're so sorry that people have to go through that in this country. Just one quick announcement. Sheriff Langley is here with us tonight. I just wanted to acknowledge that. Thank you. Now I would like to introduce Senator Gustavo Rivera, who has represented the 33rd District, Senate District in the Bronx since November of 2010. Since taking office, the senator has focused his efforts on addressing issues of health inequity, both legislatively and on the ground. In 2011, he launched the Bronx Changing Attitudes Now Health Initiative. His passion to improve the health of New Yorkers led to his appointment as the chair of the New York State Senate's Health Committee. Prior to his appointment, he served on that committee as the ranking member for 6 years. In 2018, the senator was elected to serve on the National Association of Latino elected and appointed nonpartisan officials for an initial 3-year term. The organization, by the way, has 35 board members, and we're proud that the senator is one of them. Their mission is to foster civic engagement in Latino communications, increase the effectiveness of Latino policymakers, and promote policies and advance Latino political engagements. The senator's resume of accomplishments is quite lengthy, and it shows me that
you don't read the whole thing?
I wasn't going to. I just have like one more sentence. But what his resume did show me was that he has a long history of caring about healthcare issues and knowing how to bring players together to create results. Senator Rivera is the main sponsor of the New York Health Act in the Senate. So I'm pleased that you're in Putnam County tonight, and we welcome you.
I'll remain here if that's okay.
That would be fine.
Very well. So I am very glad to be here, not only to talk about this issue, which I care deeply about, but also because I can ask you fine folks, how exactly do you pronounce the name of the place? Mahopac.
Well, it depends on if you're a native or not. If you're a
That's what I'm
native,
saying.
you say Mahopac.
Mahopac if you're
A native.
if you're a native.
And if you're only here like for 40 years like I am, it's Mahopac.
Gotcha. It's like Houston and Houston, like Houston Street
Yeah.
in Manhattan. Anyway, it's all thing. It is a great pleasure to be here. Again, my name is Gustavo Rivera, State Senator for the 33rd District in the Bronx and the chair of the Health Committee in the Senate. If you have to transport yourself from point A to point B and you need a car, I really don't have a problem if you can only get a Kia, or if you can get an Audi or a Mercedes or a Ferrari. You're still going to go from point A to point B. I don't have a problem with that. You can only afford a Kia, you can only afford a Ferrari. I have a deep moral problem when a situation like David's pops up, and he is not making a decision about whether he's going to get a Kia or he's going to get a Ferrari. He's making a decision about whether he just walks to the B in the A to the B, right? You're going to walk that 100-mile walk At least you had somebody to do it with you. It is immoral that we live in a system where that is the type of choice that we are making every single day. When individuals are making decisions about their health that have nothing to do with their health, we have a problem. The system that we have right now is broken. I'm not even talking about the folks who are uninsured. That's a population that certainly concern us immensely. I'm talking about even just the folks who are insured already. I have a friend of mine, for example. Oh, say hello. It's all good. It's all good. I have a friend of mine who is employed. She is insured. She makes a good living. A few years ago, she had a car accident, and her neck kind of, got like a little whiplash. She got a little bit more whiplash than she thought. At that time, she couldn't really afford the care that was needed to get the neck right, but she didn't really think about it. So now, years later, she's in a high-stress environment, gets paid very well, has very good insurance, but now goes to the doctor because she's like, her neck is just bothering her so much. She goes to the doctor says, oh, this can definitely get better. You're gonna have to do physical therapy though. You're gonna have to do 3 sessions a week for 6 weeks in a row. And each one of those sessions in your current plan costs you $75 a pop. So now you have a woman who is young, fairly healthy, employed and insured, and she has to make a decision about her health care. She has to make a decision about something that is really bothering her, and if it gets worse, could actually threaten her life. Just like the situation with David, where he had to make a decision about what he was going to do. And not because he wanted to be, he had to make that decision. It's immoral. It's the point. So, there's a bill called the New York Health Act, which we have introduced. When I say we, I mean my colleague in the New York State Assembly, Dick Gottfried, and myself. Along with a lot of sponsors in the Assembly, we are now up to 31 sponsors in the Senate, and I will pause for applause. Only because when it was reintroduced earlier this year, we had 24, and we're slowly climbing to 32, which would be the majority of the body. I will say that Senator Harkin, who I have permission from to be here, by the way. When it comes to the Bronx, he gets my permission. When I come here, I get his. He is a co-sponsor of it, as well as 30 of my colleagues. So, what does the bill do? And I'm going to just give some overview. Then this fine gentleman is going to go deep into wonk territory, which I certainly appreciate. We love the wonks. I love the wonks. I sincerely love the wonks. And then we'll go over here to talk about some of the actions that we need to take if you are someone who believes that this needs to be done and want to be supportive of our efforts. Now, the bill called the New York Health Act would create a single-payer system in the state of New York. Now, one thing that we need to clarify is that universal coverage is not the same as single payer. Universal coverage certainly means that everybody is insured. Right now in the state of New York, about 5% of our population has no form of insurance whatsoever. And you will hear from some of my very good friends in the insurance industry how we should be focused strictly on figuring out how to get that 5% gone so we can have 100% of the people insured. Well, that would be fine. And that is something that we certainly want to do. But covering everybody with a system that is broken is kind of problematic. So, single payer simply means that the state will be paying all of the bills. That is ultimately what it means at its core. And you can ask yourself, how is such a thing even workable? Well, besides, let's just ignore the fact that basically every industrialized country in the world has already found a way to do it. Let's ignore that. Let's say that that is not the case. Or that they have, get much better results than us spending a lot less money. But let's just ignore that. Just don't even think about it. How is such a thing to work? When you have, as the wonk shall explain later, insurance works by sharing risk. By having a pool where we all put a little bit of resources in it. All of us are putting $5 into the bucket, and then one of us needs $50, but the rest of us that particular month don't need anything. Well, we get a little bit more for the people that need it, but we keep putting it. You should really say hi. What do you say? So when you have the first way that you can actually save money in this program, when this bill goes into effect, is that The risk pool is the entire state of New York. So even the largest pool right now is a couple of 100,000 lives. And so even the people that are very, very well, that have very, very good insurance, share that risk pool with a couple other 100,000 people. Now you have one risk pool for the entire state of New York, 20 million people. So now the cost is shared across the entire spectrum. And we'll talk about the funding of it a little bit later. But that's number one. Number two, you give primary care to everybody. Now primary care makes a big difference because you can, for example, identify chronic conditions earlier. So someone who is asthmatic, who has a kid who's asthmatic. In the Bronx, for example, where I represent, you have very high rates of, well, almost every disease you can think of. We're the unhealthiest county in the entire state of New York, sadly. But for example, asthma rates are through the roof right around the Cross Bronx Expressway. So if you're a mother who has a kid who has asthma, you're not insured. That kid wakes you up in the middle of the night because he or she can't breathe. You're going to take him to where? The emergency room. And the kid is going to be breathing, and the kid is going to be fine. But that is going to happen again in a couple of weeks, and a couple of weeks after that. Not only is it the most expensive care, emergency care, but also since that particular person, and there's many of them in my district who do not have primary care for them or their children, they don't get to actually deal with chronic conditions like that, or like diabetes, which is also something that exists a lot in my district. So by giving everybody primary care, you make sure that they can go to a doctor not when they're sick, but to maintain their health. And it's kind of changing mentalities from one of sickness to wellness. So everybody having primary care means you don't have to make a decision about whether you're going to go to your doctor. Because even if you can't, if you're insured, you go to the doctor, how much you have to pay for the copay. If you're a parent, you have like 2 kids, they both have like maybe the flu, so I got to do them too. And then how much the drug's going to be, and you're calculating all that in your head. Not only does that give you all sorts of agita, but also it doesn't mean that you have a better life. And yes, it's incredibly expensive. So, primary care, giving everybody primary care. Third, very important, administrative cost. The fact is that private insurance companies who have these enormous apparatuses, have an apparatus, the purpose of which is to make sure that they give as little as possible of your money back to you in healthcare. Now there are some legal restrictions that they have on that regard, but outside of that, they will figure how to ensure that they can cover you the least possible to keep most of the money. And they have a large apparatus that does that. And that would be, depending on who you ask, definitely you can ask the one later, 15 to 18% of your dollar. How about if we actually go between 3 and 6% of your dollar to have an administrative cost? If the apparatus is not there to keep you from getting coverage, but the apparatus is there to just pay the bills to your doctor who has made the medical determination that you need certain treatment, get a little bit simpler there. Administrative cost. Drugs. You get to actually negotiate with a drug company and say, we are going to negotiate with you to buy in bulk on behalf of 20 million people. Probably you'll get a better deal than if you're negotiating with the same drug company for a couple of 100,000 folk. So all of a sudden, you're negotiating with drug companies for 20 million people, you get better deals, you save money there. And overall, folks, giving people better lives by providing them primary care, by making sure that they don't drive themselves insane trying to figure out how they're going to even be able to pay for their own care or for their families. That means that you have better lives, you got lower mortality and lower morbidity, so people die less and live better lives. That not only saves money, but means that we all have a better life. So the system we want to create, and I'm coming to an end so I can pass it to this fine gentleman right here, is one in which the premiums, co-pays, deductibles, out-of-network charges, all of that would be gone. And the way that it would work is that we would have a graduated assessment, meaning taxes based on the ability to pay. And I did say that dirty word, by the way. Taxes. I did. I am one of those crazy tax and spend liberals from the city. But I'll tell you what. Is this that we're proposing, is this expensive? Yes. You know what else is more expensive? As I said, more expensive, and gives us worse results. The current system. Because if you add everything, if you add Medicaid, if you add Medicare, if you add what you and your family for private insurance, what you're paying in deductibles, in premiums, in co-pays, in out-of-network charges, when you add all that up, you are in the $150, $160 billion range. So in other words, we are already spending that money. What I propose, what we propose, is to have a system in which there is an graduated assessment, so a tax on payroll, we get Medicare, Medicaid, we put it into a big pot, we take payroll taxes, we put it into that pot as well, and there's other taxes on some investment instruments, etc., like that sort of stuff that I never have access to. I make government money, I don't really know anything about any of that. But that all goes into a pot, and everything gets paid for by that pot. So in other words, it is a simplification of a system. I don't know the presentation the gentleman's going to do. I've seen one of he does before. And there's a slide that he has up, which I need to have, because it might look like gobbledygook once you see it. But the reality is that every single one of the little bubbles that you're going to see actually corresponds to a part of the system that is built to keep healthcare from you. Not to facilitate care, but to keep it from you in the current system. So as I bring it together, look, this is something that what we're trying to do is we're trying to fundamentally redesign the way that healthcare is delivered in the state of New York. And because we're not in some rinky-dink state, it is a model. It would be a model for the entire country. And it is incredibly complicated, both technically and politically. But it is necessary. And I don't have to tell you that. This brother right here can tell you that. And there's a lot of other folks. Matter of fact, I would bet you the $20 that I don't have on me because I didn't stop at the ATM or whatever. But anyway, I would bet you a large amount of money that every single individual in this room has some level of experience with the broken healthcare system that we currently have. And if you want to continue to defend that, as some of my friends in the insurance companies and other folks want to do, then that is fine. For the rest of us, we need to make sure that we mount up, because the battle is waging right now. This is something that needs to be done. I believe it must be done. And with everybody's help, I believe we can do it. Thank you so much, folks. So the professor is going to go out. That's right, ladies and gentlemen. It's the professor.
Thank you, and thank you for simplifying that for us. It's, I'm sure that we can now say why we're in favor of healthcare much more easily than we could before. Just a reminder to everybody of two things. One is that we are taping this, so it'll be on local TV. So we're going to reach a much larger audience also. And that to remind people that if they do have questions, there are index cards available in the back. And Eileen, what do you?
Please turn off your phones.
Oh, please turn off your phones. That's a good thing to remind people of. So I'm getting the feeling that none of our speakers actually want me to be explaining who they are. So I will do this very, very quickly with Dr. Arnow, who is a senior fellow and director of Health Policy Research and Political Economies Research Institute. He is a health economist and a distinguished fellow at the City University of New York Institute for Health Equity. He is a member of the National Academy of Social Insurance and serves on the board of directors of the National Committee to Preserve Social Security and Medicare Foundation. Dr. Arnow's recent work includes studies on the impact of Social Security and earned income tax credit on population, health, food insecurity, and the elderly, economics of caregiving, social and geographic determinants of obesity, and regulation and pricing practices of the pharmaceutical industry. We welcome you, Dr. Arnow.
Good evening, everyone. Stop me, you already got a phone. couple of your points, because they're the same points I want to make in a slightly different way. Just by way of real background, as opposed to what you just heard. For the past couple of years, I've been working with a team of economists at the Political Economy Research Institute on the economics of single-payer healthcare. And we did our analysis for the state of California, and after that we did it for the United States, for the legislation for Sanders. And we're currently actually revising that. There's another bill in the U.S. Congress proposed by Representative Jack Powell from the state of Washington, which is similar to the Sanders bill on the House side, but she's introduced long-term care, which is also in the New York bill.
I forgot to say that, it's long-term care too, it is long-term care.
Well, that was a big innovation, both in New York and at the national level, but for the past couple of months, we were actually trying to figure out how much that would add to the cost of doing Medicare for all. So, what I want to do is very briefly give you an overview of what's going on in healthcare, and then get into some of the more specifics about Medicare for all at the national level and somewhat at the state level. And if there are questions, which there should be, just let me know. All right, so this is what healthcare looks like in the U.S. at the moment. About 1/3 to 1/2 of all GoFundMe, whoa, I can't see. Is this a light?
No, there was a light here, but I didn't know how to turn it on. It didn't seem to work.
You gotta roll the punches, bro, you gotta roll the punches, bro.
So,
All right, here we go.
turn the light on for Erica.
All right, well, I'm just going to keep going, unless you get some light on something. So about 1/3 to 1/2 of all GoFundMe accounts in the U.S. go to pay medical bills. Last year, Americans had to borrow $88 billion just to pay for health care. And this is even under the ACA, where there continue to be exorbitant healthcare expenses that drive people into bankruptcy. And as you know, healthcare is the largest cause of bankruptcy in the country. Now, we know that healthcare spending in the U.S. is out of control. What this graph shows you, to the extent that you can see it, the top line is the United States spending per person. And you can see back starting in the early 70s, the U.S. was basically on par with most of the other European countries. But it has taken off. And so we are far beyond what other countries pay for their health care. In fact, we are paying about double of what other advanced developed countries have. And as the Senator reminded us, all these other countries basically have universal health care programs that insure all their people. Whereas in the United States, we're talking 30 million people with no insurance. And in New York, it's a little over 1 million today. All right, so what's going on with insurance and what we pay and why the media pundits seem to think that we love our health insurance so much? The top two lines, if you can see them, the top line is what workers contribute to their health care premium. The orange line, the second line down, is the increase in premiums that we paid over time. And the two bottom lines, the blue one is basically wages, what people earn, and the bottom line is the inflation rate. So as you can see, what's happening is premiums are going up, workers' contributions to those premiums are going up, and So it's going up. And that didn't even include deductibles. I want to spend a minute on the deductible thing, because deductibles are one of the key mechanisms that have been employed over the last few years to supposedly help curb costs, but what it really does is make care unaffordable. And what these lines show, from left to right, is from 2003 to 2016. And as you can see, the two charts on the right are this one is deductibles between $1,000 and $3,000, and the one on the right is deductibles over $3,000 a year. So what's going on is a huge increase in expensive, really raising and ratcheting up what the deductibles are. And in 2018, the average deductible for single coverage is now $1,350. So healthcare costs are rising, premiums are rising, deductibles are rising, and as a result, we still have healthcare as the main cause of bankruptcy in this country. And where does that take us? Let's see. And what do New Yorkers think about all this? Well, this is very new data that was from a survey done in New York between December and January of this year, where basically all it says is that overall, most respondents, 64% of New Yorkers, were either worried or very worried about being able to afford health insurance in the future. And this is a breakdown, and this is only among insured people. This is a breakdown of whether you are employer-based or you are covered by Medicare or single insurance coverage or Medicaid. Everyone's worried. So, do workers really love their insurance? Well, this is New York again. This is just the big picture of New York, what as recent data as I have seen, that shows you that basically 1 million New Yorkers, well, this top of the slide's not down, but more than 1 million New Yorkers are uninsured. And it is the breakdown, how many have Medicaid. And again, what the senator said about what we're now paying for insurance, the public dollar is paying for between 60 and 70% of all healthcare expenses right now. So if you could take that public money that we're already spending and apply it to a single payer system, then all you have to do is make up the other 20 to 30%, 30 to 35% some other way, and that's where the taxes come in.
Dude.
Someone has something to say? So, again, I want to harp on this. Do workers really love their insurance? We've got rising premiums, rising deductibles. We have growth in these limited and narrow provider networks. And do we really get to keep do workers really get to keep their insurance? And the last question is, does this insurance ensure their access to health care? Now, this goes right to the question raised earlier by the senator, and it's raised yesterday in the congressional budget hearings on single payer. Well, if you only have 5%, why blow up the whole system just to cover that 5%? Right? I'm going to answer that question to the best of my ability. And it's about what's not talked about frequently enough, the underinsured. And I'll just read the top. The underinsured are individuals and families who are covered by health insurance for the entire year, but their insurance policies include deductibles and other forms of cost sharing that are prohibitively expensive. And the Commonwealth Fund does this biannual survey where they ask people all over the country, including in New York, these questions about does the cost of their, the co-pays, the deductibles, and so on, prohibit them from seeking medical care that they need. Filling a prescription, seeing a specialist, getting the test they need, or just visiting the doctor. And that's the definition they use for measuring what I'm calling, and what they call, underinsured. And this is from a parade in New York about covering the uninsured and the underinsured. Some of you might have even worn those costumes. I bet you wore one of those.
That's her on the left.
From what I hear. Okay, well here's the data from New York. So this is 2016. And by the way, the 5% that you keep hearing about, it's not, I would not say it is 5%. Perhaps if you include the entire population, but that's not really a fair metric, because once you reach 65 and you have Medicare, you're insured. Everyone over 65, 98-point-something% is insured. So the population to look at, for adults at least, is 19 to 64. And in 2016, 9%, not 5%, but 9% of New Yorkers were uninsured. Now I looked at the data, the latest data that we have is for 2017, and yes, so the 9% went down to 8%. Okay, so it's dropped 1%. But the underinsured, by the definition I gave you, represents 27% of everyone in this age group. So if you add that together, you're talking about basically a third of New Yorkers do not have access to health care. And that's why the 5% figure is bogus. And that's why it drives home the point of why we need a system like a Medicare, within a Medicare for All framework that would cover everybody. The uninsured, yes, but also the underinsured. And again, these people, let me just repeat, the 27%, the 2.7 million people you see here have insurance for the entire year. But they just have high co-pays and deductibles, et cetera, that I showed you earlier, which prevents them from getting the care they should have. All right, so let's take a look at what's going on in the healthcare system. This is not as fancy as the chart you're looking for. We'll get to that one in a minute, but this just shows you in light, whatever color it is. What color is that? Blue? The rise in the administration of our healthcare system. And yellow is the number of physicians. So this is just a graphical way of showing you the rise in administrative burden that our system is under. Now, I couldn't help add this chart. This just came out a couple of days ago. This is unfreaking believable. What this chart shows, all these different colors, yellow, blue, purple, those are different segments of our system. They're hospital services, medical care services, professional services, but the red line is the price of health insurance. Now, I'm just going to break this down slightly. Each one of those dots represents how much the price went up from the year before. So in April of 2019, this past month, last month, health insurance, the price of health insurance is 10.7% higher than it was in April 2018. That's what that means. The other thing that's just jarring is that this is not about the premiums they charge either. This is about the retained earnings of the insurance companies, which means this is exclusively their administrative costs and the profits they generate. That's what's going up dramatically. You have to ask, what the heck's going on? And Only thing, we don't know, it looks like an egregious insurance, 30 seconds.
You've got 30 seconds.
Oh my goodness,
How much longer do you need?
I don't know, more than 30 seconds.
That's the one, right there, that's the one.
This is an actual accurate graphic done on the claim system in our health insurance. It's virtually impossible to read, but this is the kind of complex, crazy, convoluted structure that the insurance companies have designed. And a lot of it is to deny care, actually, and make sure that they pay as little as possible to keep those retained earnings as high as possible. And here's the other side of the picture, one of the other reasons. This is just the 2016 CEO salaries of the insurance executives. $30 million a year, $40 million a year. And I was wondering if Humana guy at 17 was jealous of Helmsley and United Health and Bertolini. Okay. All right, so single payer, this is the basic tenets, right? Everybody gets an insurance card, full coverage for medical care, no premiums, co-pays, deductibles, prescription drugs are available, and free choice of your own choice of who you go to see for medical care. All right, now, we don't have a whole lot of time to go through all the numbers on what I'm going to do, but I just wanted to pick this one out, because this is from our own analysis, national analysis. It's not that different from what New York. But again, this reinforces what you heard earlier. The two biggest savings that you would see in a single payer framework is administrative restructuring, getting rid of a lot of the administrative waste that comes along with the private insurance. And by the way, that affects not just how much we pay, but it also affects providers, because they have to hire armies of people to take care of all the paperwork. And the other big factor is drug pricing. We all know about that. And so those are the two biggies. And you probably can't see this too well, but let me just say, this is per capita drug expenditures. Here's the US, and here's the rest of the developed European economies. And again, just like healthcare expenditures in that first slide, this is showing you that we are paying double what everyone else in the developed world is paying. And the middle number, the European average, is $594, US is $1162, and this is from 2015, so it hasn't gotten better. This you can't see at all, so I'm probably going to just let it go. Oh, and you want to know how we paid for it. Well, this is our national study. Again, things are complicated, but conceptually they're not that complicated. We pay a whole lot for health insurance. We do single payer, it costs us less money. Yes, we need to raise some money that we're not raising now. This is how we design it to be raised at a national level. Businesses would pay about 58%, and families would pay about 42%. When you do it, and we designed it so that the premiums for all businesses that provided insurance would immediately have an 8% cut. And if they had uncovered workers, they'd have to pay $500 per uncovered worker in the first couple of years. And for families, we had a 3.75% sales tax, excluding non-necessities, so food, housing, utilities are all excluded. There's a small net worth tax that exempts the first $1 million, and there's also converting long-term capital gains to ordinary income. And we needed $1 trillion in the US to do this nationally. And that's how we get it. But there's many ways to do it. In California, we did a gross receipts tax on businesses, very low. In New York, they're doing, I can show you, I think. This is New York. This is, Len Robert did this one. And basically, it's not that different from the national thing. He has long-term care in there. And he's showing you that even with long-term care added, you have net savings of close to 4%. Again, covering everyone. I just wanted to mention this one thing. This is coming up over and over and over again, and particularly at the national level. I don't know how much this is happening at the New York level, but everyone, the centrist Democrats in Washington are afraid to do single payer. And so they say, well, what about a Medicare buy-in, choice? America loves choice. Can't we keep our commercial insurance? And these are the main reasons why I think all of these plans are inferior to a single payer approach. They have no ability to rein in the costs, number one, because the administrative costs still there because it keeps the commercial insurers in the mix. They don't reduce pharmaceutical prices, and the premiums, co-pays, and deductibles are all still there. So, and you don't get universal coverage. So how, I don't know what they think is so great about it. And, sorry. You looking at your watch or what?
Cough.
All right, almost done. And I want to just, maybe I'll end on the choice of business, because that's another phony issue. Do we have consumer choice now? No. We have these narrow networks. If you're uninsured, you have no choice. If you're underinsured, you have few choice. And if you change jobs, lose your job, even with the same job, your insurance can change at any time. In 2018, 66 million workers were separated from their employment. That means, and maybe they didn't all have insurance, but all of them had to switch their insurance if they did. And even among those that don't leave their jobs, something like 25% of all employers switch their insurance every year. So keeping your insurance doesn't happen now. So switching once to a universal system sounds like a good deal. All right, you all know about seniors and Medicare, we'll skip that. Oh, this is the first Medicare card. All right, I'm going to end here, but just say that when we can talk about the transition to it, but in 1965, you know, they converted the entire system in a year, and that was without computers. Now, yes, it was fewer people, but remember, today, 10,000 people per day are switching into Medicare, roughly. So, yes, we need to ramp it up, and there are transition costs, and we need to talk about that. And in our analysis, we actually costed out what those would be in terms of lost jobs in the insurance sector and so on. So, I couldn't resist. The waiting list thing is also one of these buggy boos coming up over and over again. Oh, the waiting list, really. This is a perfect example of how stupid the Council on Economic Advisors are. They put this out in the President's report in October of 2018 to prove how bad single-payer universal coverage is by showing you the wait times in all these countries and the United States, and it's for seniors. So basically what they're showing you is that the Medicaid program in the United States has the lowest wait times of any of the European countries. So it proved exactly the opposite of what they were trying to do. And if anybody wants to read our analysis, see what we have, the details of it all, you can just go to our website. It's free. You can download it and have a look. Thank you very much.
Thank you very much. We appreciate that. And a lot of the questions that people have asked, actually, Dr. Arnall has answered. So that's very helpful. Katie, we're going to introduce you now. And Madeline Zevon, who's the chair of the Health Committee for League for both Westchester and New York State, wanted to make sure that we let everybody know how much Katie Robbins has been a help to the League of Women Voters and how Madeline considers you to be a mentor for her. So that's very good. Katie is the executive director of the Campaign for New York Health and has been one of the outstanding leaders in using grassroots advocacy to advance the New York Health Act. Prior to her current position, Ms. Robbins was the Executive Director of the New York Metro Chapter of Physicians for a National Health Program. And we welcome you, John.
Good evening, everybody. What a pleasure to be here. So my task tonight is to basically get you organized. And so the first thing I did was hand out these postcards to the state senate. And what you can do is if you want to get involved and stay connected to our campaign, you can fill that out. Let us know if we can send you text alerts. Let us know if you have stories to tell. Turn it in to me before the end of the event, and we'll make sure those postcards are delivered on Tuesday at the very first joint Assembly and Senate hearing on the New York Health Act happening in Albany. It is a big deal. Thank you. It is a big deal that we are at this point. I frankly have been working for about a decade, a little over a decade, to have a fair debate on universal public health care. And it is really, really exciting that that debate is starting. But I don't want to minimize the work that needs to be done to get us from where we're at politically to where we need to go. But I will say that as the Senator and Dr. Arno explained, this is a crisis when it comes to healthcare. On the grassroots side, we have taken a different approach than the academics. We've actually taken surveys and gone out all over the state, knocked on doors and tabled in public, and we had conversations with 2,409 New Yorkers over the last year and a half about healthcare. And then we, over the last few months, crunched that data, and we found 50% of the respondents delayed or skipped care because of cost. 50%. And this isn't like, this is basic care they're skipping. Preventative checkups, vision, dental, diagnostic procedures. And I know personally I have absolutely been in that boat in a number of ways. The way access to healthcare has affected my life is pretty significant, In 2010, my now husband actually had a kidney stone, and he was an uninsured filmmaker. And he, there's a debate, what's more painful, the kidney stone or childbirth? And I know one woman who has been through both, and she said kidney stone. And he, as an uninsured person, didn't want to go to the ER and get the bill that would come with that. So he self-treated at home. It took about a week. It was really sad to watch him go through that. And I said, call your mom, get permission. We are going to City Hall to get married so you can get on my health insurance plan, which was about the most romantic thing I could have said. And that's what we did. We got married for health insurance. Now, I can tell you this story ended pretty okay, and we still like each other, and I was married 10 years later, but I also worked in DV shelters right when I got out of college, and domestic violence shelters in rural Ohio, and I know that people stay in marriages they should not be in because of health insurance. You have a chronic condition, or your kid has a chronic condition, sometimes that's not something that you can risk in terms of access. So this is not just about the dollars and cents of the issue, this is about how our access to healthcare controls aspects of our life that it's really bad. And we can change it. We're not reinventing the wheel. We have examples in this country of public programs that work and guarantee access to care for people who are eligible. We have examples around the world. So it's really not, we are right. We are right about the policy. But it's a political issue, and that's where all of you come in. We need to win this together. So the Campaign for New York Health, which is a statewide network of advocates, we work very closely with the New York State Nurses Association, Physicians for a National Health Program, and many, many other groups. We encourage everyone to feel like they have a stake in this campaign. And actually telling our stories is one of the most important things you can do. And so I'm really glad this event actually started with that framework about what it's like living in fear of how you're going to access or pay for care. And it's something that we need to do more of. Because what telling our stories does is actually helps break down the shame that sometimes surrounds. You know, there's just bad feelings you get when you can't afford care or you don't get the things you need for your family because you don't have the money. And when we speak out about this, it helps us to understand we're not alone. It's not an individual problem. It is a systemic problem. So I really encourage people to think about how this impacts you, and then I need you to think about how you are going to most strongly communicate that to your elected officials. We're in Senator Harkin's district. Senator Harkin is one of the first co-sponsors this year of the legislation, the New York Health Act in the Senate. We were so excited to see that. But he also needs friendly, supportive reminders about how important it is to you and that he needs to make it a priority, right? I'm seeing some nods. Also, this is taking, the window on the national fight for Medicare for All is opening, so making sure you're communicating support and why this is critical to you, to your congressperson, is also very, very important right now. In addition to that, there's lots of ways that you can help shape the way this narrative is framed. We have different tactics. We have a physician's petition right on our website. You can go to nyhcampaign.org. As an individual, sign on. You can tell your story. You can, if you're a provider, sign a petition joining thousands of other providers calling for real reform in the New York Health Act. If you're a business owner, you could help us counter the opposition argument that somehow giving everybody health care and guaranteeing it is bad for business. That's something they say. And we have gone out and we have almost 500 businesses that have actually endorsed the New York Health Act, saying it would be a huge relief to be able to have an affordable plan that covers not just the business owners, but their employees. So speaking out and making that support visible is so necessary. I see the lawn sign over there. That is excellent. But we also are encouraging people to organize, take this information. Do not keep it to yourselves. Share it with your neighbors. Perhaps there could be a door knocking or phone banking party in the near future to communicate how important this is to people who also live in this district. If you're a super volunteer, we actually have phone banking going on so that you can call constituents who live in districts where the senator hasn't yet co-sponsored. That's super volunteer level. I might be able to recruit some of you for that. But this is the moment where we're at. We're in a legislative fight, and we need people involved to make sure that we get this across the finish line. I think I'll just wrap up by saying, oh, and one more thing about action items. Who here is going up to the hearing in Albany? Can you raise your hands? You were just there last week? You're not gonna go again? I see some hands up, so maybe there's some carpooling that can be arranged, because we are taking on some of the biggest industry heads in the state on this issue. The opposition is they've been taking our premium dollars and basically banking them so that they have a ton of money to run a misinformation campaign about this proposal, and that is exactly what they're going to do. So we need you all to be inoculated to the kind of arguments you're going to be hearing from folks that somehow, when you have universal health care, it will be way too expensive. Well, we just found out that people can't afford the current system, or that you're going to have horrible wait times. Well, we saw that if we have a Medicare model of reform, it actually could be the best healthcare system in the world, that somehow this is going to destroy business, that rich people will flee the state. Millionaires are moving to New York State. They are, they're not leaving. So this is a battle around the politics of this moment, and it's really, really important that you step up and make it a point to prioritize this and communicate it to your elected officials and your neighbors. So that is where I will leave it. Thank you so much for the opportunity to be here tonight.
Wow, we're so happy that you were all here to give us the information that you just did, and we have quite a few questions from our audience. And I don't think we're going to get to them all, but I have
I don't know,
some
I speak
together.
very quickly, so maybe.
Sure.
I speak quickly, so might get real questions this morning.
That's, I'll go real quick. So the first grouping is if the federal waiver, Medicare, et cetera, do not come through, will that cause a reverse or a shortfall? Could you talk a little bit about that, and how would healthcare for all New York State fit into the larger system that's going on that is nationally being considered?
So two things. First of all, it is obviously the best choice is to have a national single payer system. That would be a much better option. But that is certainly under this administration is unlikely to happen. And so we have in the state of New York, not only do we have one of the few states that has the makeup tax structure, like as far as the people who live here, as far as the number of population, and the type of folks who live here that can actually finance it, excuse me. But as I stated earlier, I believe that we have a moral obligation. We can do it, and we should do it. Now, as far as the waivers, now for those folks that don't know exactly what that means, there is, when you are using federal money, either Medicaid or Medicare money, mostly Medicaid money, in ways that is not the normal reimbursement that you would get, because it's 50-50, so the state puts in their state share for every dollar, there's 50 cents that's federal or 50 cents that's state. Whenever you want to use Medicaid money in a creative way, you have to get a waiver. We have gotten many of them in the state of New York because we've been kind of ahead of the curve in the ways that we spend Medicaid money across the nation. So getting a federal waiver to do this would make it a lot easier. But we do not need a waiver. It would make it easier, but we do not need a waiver. We would do it as a wraparound service for the current Medicaid system. It would be complicated, but as my colleague in the Assembly says it often, there's a big part of the big chunk of the complicated part would be managed by a robust computer system. And as long as we can keep track, because ultimately it's about whether there's like individual A who is Medicaid eligible, and the 50 cent that we're getting from the federal share that needs to go to this person, we just have to make sure that we give the information to the federal government saying like that 50 cents is being used for this particular Medicaid patient. And so doing that through, it'll basically be a system that is not visible to any of us as patients, but it would be state managed. So again, a waiver would make it easier, but it is not necessary.
Thank you. We have quite a few questions that I think I'm going to read all together because I think they all have to do with the specifics of the care. So a few people have asked about dental care and eye care being covered.
Yep.
We have a question about women's reproductive health issues.
Yep.
Will people be able to choose their own doctors?
Yep.
And would they have to give up, if they've gotten benefits now that are pretty good from their businesses or their other systems, would they have to give that up?
So let's pause a second.
Okay.
Number one, as far as when I said yup, when you're talking about choosing your own doctor, and folks might think that's a flippant answer, considering that there was a similar question asked during the whole Obamacare debate that didn't end too well when the president then said you get to keep your doctor. This is the thing. What we're trying to do here is we're creating basically one insurance product. That's it. So we're creating one network. That's it. Regardless of where you live, regardless of your age, of your gender, of how much money you make, if you're a resident of the state of New York, because it also includes folks that are undocumented, if you are a New Yorker, you will be in the one system. So basically, the doctor would have to accept it because it will be the only system. We would actually write, it's actually written into the law, that anything that is offered by the New York Health Act, it would be banned that a private product is sold that does that. So it means anything that is medically necessary. Now, we're not talking about things that aren't, but things that are medically necessary as determined by you or your doctor would be covered. Now, as it relates to the current insurance product that you have, now there's some numbers that we put up, like that you put up related to this idea that people like what they have. That's certainly understandable. But what we're offering is to create a higher floor for everybody. First of all, and this is something that was important, that was not mentioned, that I didn't mention, but you reminded me of it. Actually, no, Katie reminded me of it, and I should mention it. The product that we offer, the New York Health Act, will cover long-term care. Period. That is an important part of this. The reality is that if, I figured that there's many people in this room that have some level of experience with long-term care, meaning they have family members, friends, neighbors who have required some form of long-term care. And currently, as you see, when you see insurance products or managed long-term care plans, not only these plans are ultimately, they're self-defeating. Remember the conversation? Oh, somebody else. Say hi. Please say hi for me. So remember the conversation we had right at the beginning that related to risk pools, right? Everybody puts in a risk pool. So if you're talking about managed long-term care, basically, in a normal insurance product, right, we would all be insured, but then I get a cold one day, and God forbid somebody else breaks their leg the next month. But long-term care, by default, everybody is a high-end user, because even at the bottom end, everybody needs something, not 24-hour care necessarily, but anybody who needs long-term care as a basis will obviously be, it's an expensive thing. If you have only in a managed long-term care plan, if you only have people who are long-term care users, those plans are basically they can't be maintained. It's the reason why we've seen them implode in the state of New York over the last couple of years. We figured that putting every long-term care case into the larger pool actually makes it so that everybody has access to it when they need it, right? And as you said, if you have primary care, you have lower mortality, lower morbidity, you actually might avert some of the needs that you might have in the long term. So the short answer is, what we're offering is going to be better than what you have across the board. And if you tell me that you have a product in which you pay no premium, no copay, have no deductible, and you're always a network, then keep that. But I think you probably don't have that. So.
Thank you. I have one question that I think you can answer with one word. If you travel out of New York, are you covered?
Yes.
Even in Texas?
Dude, if you're traveling to Texas on your own, bro. For the record, for the camera, no, you're still covered.
A person.
You might get me calling you, asking you like, why? But besides that.
A person did give us an interesting story about some emergency care that he needed, or she needed, and would like to know if there's something in here that will avoid the unexpected billings that people get from emergency care.
Yeah, absolutely. I'm in the middle of, I don't want to go into this. I'm in the middle of something that relates to the current system and something that we're dealing with, surprise emergency billing. The answer is there would not be surprise billing because everything would be paid for by the plan. So there would not be a surprise billing. The bills do not go to you.
And would it also cover some of the specialty cares like chiropractors and neuropathy doctors, etc., and supplements? Naturopathic doctors? Yes, sounds right.
I don't remember the bill actually. I have to.
Okay.
I will have to get back to you on that one. So,
Well, there's some.
Ma'am.
Yeah,
Oh!
Oh.
I'm sorry, bro.
Sorry, we almost got through the whole event without it. Oh well, I think we're gonna be okay. Well, let me just move this. Regarding what the bill covers, the way it's written, is that anything that is currently covered by Medicare, Medicaid, and the state employee benefit package, and then long-term care in addition to that, is covered by the New York Health Plan. So it's more generous than any existing public or private plan available today. But specifics around naturopathy would be worked out through an evidence-based system for its effectiveness. But chiropractor is covered, acupuncture is covered by these programs, even some kinds of therapeutic massage is covered for certain conditions. So it's very, very generous in the benefit package, which is by design, because we need a lot of people to support this plan in order to get it across the finish line. Thank you.
Thank you. And these three questions go together. So will everybody pay something?
No. There's some people who won't. Like, for example, just like Medicaid right now, Medicaid patients are by default folks that can't afford health care, so they are covered even though they can't pay it. So it would be based on your ability to pay, graduated assessment based on your ability to pay. Also folks who are retired and now on Medicare and are of Medicare age wouldn't pay anything either. So some people, not everybody will pay something.
Thank you. And would you give an example of how much this would save the average person, and also if there would be a savings for the municipalities and businesses?
Well, I'm sure that this gentleman can go much deeper. I will tell you that we have there's different studies that have been done that say that over 95% of New Yorkers would pay less than what they're paying now. Just to give you an example, by the way, the tax rate would, the reason why there's not a particular number that's locked in the bill itself is because it depends on, the tax rate depends on how much the whole system is going to cost. So once we make that calculation, we'll work backwards from that. But we made a calculation, some of the folks that have been working with us, some of the scholars that have been working with us, have made some numbers, and in one of the, I think that this is related to there was a study that was done by an organization called the RAND Corporation, came out late last year, and one of the things so based on those numbers, we figured if your annual income is $50,000 a year, the way that it works out as far as the tax is that the employer pays 80% or more, and the employee pays 20% or less. If you are self-employed, you would pay the whole thing. But in this case, for example, somebody who makes $50,000 a year, the tax rate would amount to $4,500 total dollars a year. So that would be $900 for the employee and $3,600 for the employer a year. So this is an example. Like, I don't know. I mean, I was talking to somebody the other day who is paying, it was actually somebody that came to a town hall like this in the city, and she said that she had found out that she was insured, she found out she had cancer, and she pays like about $1,100 a month on premiums. Yep, and the deductible is $4,000. So that means $15,000 a year, just straight up, without figuring out any drugs, any extra treatments that she might need, physical therapy, whatever, $15,000 just to make sure that she can have access to an insurance product that will take care of her cancer. And this is a better situation than the one that this brother found himself in, because he didn't have insurance at all. So, although I can't, there's different studies, and I'll pass it to the scholar who might be able to give you more specifics. When you think about something like that, when you think about the fact that we are all paying into it, and as I said, some people would not because they can't afford it, but they would have access to the same system. Because we're all putting something into it, we all share the cost, and certainly the folks who can afford more and pay more, we're all getting the benefit out of it. It's like we actually will be saving quite a bit.
I would just add the current average insurance premium in the United States today, in 2018, is $19,000 for employed workers. Now, of that $19,000, about $14,000 is paid by the employer, and about $5,500 or so is paid by the employee. But as most economists would agree, if that wasn't the case, if the employers weren't paying that huge amount towards the coverage, maybe not all of it, but a good part of that $14,000 would ultimately end up as higher wages. And that's one of the reasons that wages have been so stagnant over the last 20 years, because insurance costs have gone up and up and up. The only other thing I'd add about how much we pay, how much the New York bill or the federal bills would cost us, they only increase the cost to the top 10%, roughly, income earners. Because unbeknownst to almost everyone, those people today, the people at the high end who have the Cadillac fancy insurance plan, are actually being subsidized by all of us. And the reason that it's true, we're actually paying for that care. And the reason is because of the huge deductions that the employers get off their taxes by contributing that insurance. And that's not a made-up number, it's not an accounting fiction, it's a line item in the federal budget. $330 billion a year is what the public subsidizes employers who provide health insurance. So we're subsidizing the wealthy for their health insurance. What Medicare for All does at the New York level or the federal level is it evens the playing field.
Could you expand on that for one quick second? And will the employers under the current, under the new proposed system still have to pay for their employees at all? How would that work?
Yes, the way that it works is that it would be, since we're talking about a payroll tax, the breakdown is 80% to 20%. So 80% or more, because in certain instances, there might be, if you have a unionized workforce, they might actually negotiate with their employer so that they cover more than the 80%. But the requirement would be 80% or more, and no more than 20% for the employee.
Is it different for small businesses?
It would be the same for small businesses.
Thank you. You were going to add something.
I was just going to add, I actually work with the New York State Nurses Association, the largest nurses union in the state, and they are vociferous advocates for the New York Health Act and Medicare for All because they see on the front lines what is happening. People are showing up sicker and sicker, they're not getting the care they need. But in addition, they are, a big, part of the labor movement in New York State and feel very strongly that this bill should work for unions and those who are union members who've been part of collectively bargaining their contracts. And there are union members who are concerned, is this going to be better than what I have now or not? And the thing is that when we talk about this, we talk about winning guaranteed health care because even with the good union contracts we bargain now, we have to go back to the bargaining table every few years. And every time, healthcare costs have gone up. And we're trading more and more of our wages and other benefits to keep shoveling money to the private health insurers who are trying to cover less and less. So even those of us who feel we have good union plans right now, it's really only a matter of time because there's no plan for dealing with the skyrocketing costs overall. So we would just advise people to think, a bit longer term about doing these calculations. We are talking about a solution to the cost crisis and one in which there's a future where we can bargain for increased wages and other benefits, can you imagine? Besides just healthcare, pension, retirement. My generation is struggling with student loans, childcare. There's a lot that could be done if we had that money freed up.
Great, thank you. There are a few questions about the New York hospitals, and is there a sense that they're going to be very unhappy with the bill or leave the state? I'm not quite sure how a hospital would
I'm not sure how a hospital would leave either, but I would tell you that it's a mixed bag. Some hospitals, certainly I have, for example, a hospital right in the core of my district called St. Barnabas, or SBH Health System, which is it's an incredibly needy area of the Bronx. It has a high Medicaid population, it serves a very needy population. The institution, certainly the person who leads the institution, Dr. David Perlstein, is a big supporter and a vociferous supporter. I like that, vociferous. I'm going to use that. Vociferous supporter of the bill. Other institutions, not so much. Some of them quietly are opposing the bill as individual institutions. The Greater New York Hospital Association has come out against it. We are in continuing conversations, and what I can tell you is that we are, when I say we, I was meaning my colleague in the Assembly and myself, as well as other folks who are working towards it. We are open to folks who in good faith have things to add to the conversation and have tweaks to the bill that will make it work better. But there's some that are happy, some that are not, some that are engaging in good faith conversations, others who are not. And I'm going to say that we still will get it done.
Could you share how you feel, what do you think is going to happen with the bill when it gets to the floor? Do you think we have a chance of passing it? What do we need to do to get it passed, and what do we need to buy in all the people who are opposed right now?
We're still many steps from that. I would say that just so you get a sense, the bill has been around for maybe a decade. It has passed in the Assembly for the last 4 years in a row. But the reality is that because the Senate was controlled by Republicans for a very long time, it was clear to everyone, supporters and opponents alike, that the bill was never going to move. Now that we have a Democratic majority, that means that folks are engaging in ways that never engaged before, both opposition and supporters. And the reality is that many of my colleagues have had some questions, and many of them are incredibly legitimate concerns. It is the reason why we started when I introduced the bill, the new version of the bill, in February, I think, or March or something. We had 24 members of the Senate become sponsors. Now we have 31, so I've had to work on them individually. Some of them have more concerns than others. There's some folks who, I'm not sure if they're ever going to jump on. I'm actually talking to a Republican who's open. I will do nothing to tell you who that person is, because I do not want to jinx it, but I think that there is so the first thing that has to get done, I mean, I have 31 members of the Senate that are co-sponsors. I would certainly like to get to 32, which would mean we have a majority. That does not automatically mean that we get to actually put it on the agenda and then pass it out of my committee. It also has dual reference to finance, which means it goes to the finance committee as well, because it obviously has a big financial component. At this point, we only have 3 weeks in the Senate session left. It's pretty much certain that it's not going to move this year. And part of it is, I mean, listen, we are learning how to be a majority. For those of you that pay attention to politics, back in 2009, when the Democrats were in the majority for a short period of time, to say it was a clown show would be to treat it very kindly. And there were a lot of people who had every expectation that when we took over for it again, it would be the same thing. Many of us, certainly I've been in the Senate for 9 years, my 9th year in the Senate. I knew that a very important part of our preparation was to make sure that we could responsibly govern and demonstrate to every New Yorker that whether you agree with us or not, we can at least run government. And that was the #1 priority. We needed to get over the budget. That was a huge, huge lift. I will not mince words here. Whether the things that we've been able to achieve this year, we've achieved in spite of the governor, not because of the governor. The governor is not a good faith actor in everything. Sorry, he is just not. And so this is all to say that at this point, there is not enough time to move it out of committee in the Senate, to move it out of committee, both committees into the floor. My goal is to build momentum for next year. But I realize, again, that it's a very steep uphill battle. But I'm willing to wage it. So that's where we are right now.
That's great. I think a lot of people here would like to help with that. Katie?
We have some ideas.
Oh, good. Let's share them.
Well, if people have signed the postcards that I handed out earlier, I hope you will turn those in to me. That's the best way to get connected to the campaign. But also you can go to our website, nyhcampaign.org, sign up to join us in phone banking, sign up to tell your story, sign up to canvass your neighborhood. These are all great ways. We have letters to the editor team if writing is your thing. You can work with us to set up a lobby visit to your elected officials in the Senate as well as Assembly and in Congress. There really are a lot of ways to get involved. going to the website is the best way to get plugged in, and we have a lot of fun materials in the back too, so you can pick these up, spread the word to your neighbors and colleagues, people you work with, and family and loved ones, and all that good stuff.
That's great.
Thank you.
We have four people that Assembly and Senators that represent Putnam County. I know you mentioned that Senator Harkin is a sponsor. We have Sandy Galiff, Kevin Byrne in the Assembly, and Sue Serino in the Senate also. Could you give us any ideas of where they are?
Sandy Galiff is supportive in the Assembly. Sue Serino has not come on board yet. Wow, it would be great to get a Republican to join our cause. We would love that. This is not, healthcare costs are not partisan. It affects everyone. And we're seeing polling that shows a slim majority of Republicans supporting the concept of single-payer healthcare. So,
And Assemblyman Byrne.
I'm not 100% sure. I would have to double check my list.
Thank you. We have a few side questions. One, of course, somebody asked about non-citizens being covered or not.
They're covered.
Thank you.
And let's be clear about this just for a second. Currently, someone who is an undocumented person, because they're still a human being, they're going to get sick. And if they get sick, they're going to go to where? Emergency room. We already talked about this a little bit earlier. Emergency room is the most expensive type of care. Now, if I do not believe that there's anybody in this room who believes this, sadly I think some of my colleagues in the Senate do. If you believe that if somebody is sick and they cannot afford to get care, that they should die, then certainly I got nothing to say. But if you believe that there's a basic responsibility that we have to each other, then we got to figure out how to pay for those folks who might not be able to afford it, and yet, because they are humans, are going to get sick. So as far as undocumented care, folks who are undocumented get sick, they go to an emergency room, somebody pays for that. You know who does? We do. The taxpayer already pays for that. So how about, as opposed to giving them the most expensive, less effective, I mean, it certainly might keep them alive, but if you're thinking you got a pain in your stomach in the last 4 weeks and you don't have a doctor to go to, so you're just going to go when you cannot go to sleep because the pain is so great, and then you have to go to emergency surgery upstairs and have something removed from you or what have you, as opposed to that, how about providing that person with primary care so that they can get it looked at before it gets complicated, and then it can just be like, I don't know, take this pill. And a couple of, have some bowel movements and you're good to go. Like, that's the type of thing that we need to remember. The care we already pay for, and it is more expensive and less effective. So yes, undocumented people are covered.
Thank you. One person asked if we could join with Massachusetts and California to negotiate collectively and save even more money.
There's actually, and again, I would go to the scholar on this, but there are some ideas floating around of the potential to have different states kind of join forces, kind of like a Justice League type situation, Superman and Aquaman. We're not Aquaman, by the way. We would never be Aquaman. So that's a possibility. But for the moment, I certainly believe that we are the state that is farther ahead in making this a reality. We're actually even farther than California is, because even though California did pass it out of the Senate, it went to the state assembly over there and it died, and the governor was never going to sign it. There were a lot of issues with the one over there. They didn't have conversations with labor during the process. We're doing a lot of that work now, so we're ahead of the curve. But it might be a possibility at some point to do some Justice League type of situation.
That's great. How likely would it be for New York to negotiate with Medicare for that pool of money? I think you already answered that.
Yes. We talked about the realities that we would be, if there was a waiver that was given to the state of New York to use that money, both Medicare and Medicaid, to put into one pool to serve, to be a big chunk of the New York Health Act fund, then, it would be easier.
And there are just two other questions. How do you deal with the fears people have of losing their own doctor?
That's a difficult one. And listen, I understand. We're having this issue, for example, talking to our brothers and sisters in labor. If you're telling me, and this, I heard this conversation, it was like, I have this, I've negotiated for this, I'm holding it in my hand, I can get it in my head, it's a solid thing, it's a real thing. Can you guarantee me that what you're about to offer me is at least this? And I gotta keep saying it, yeah, it's better than that actually. What we're trying to get you is even better. We're trying to create a higher floor for everybody. But it's a difficult thing to deal with the unknown, right? So I would say that these types of conversations are an important part of it, so that we can ask the questions, educate ourselves, and continue down the road. If we get it right, and we must get it right? This is one of the reasons why we want to make sure that we have all these conversations, all the legislative conversations we're having, make sure that we engage with good faith actors to make the bill the best that it could possibly be, because we cannot get it wrong. But that's what it's difficult to get people to give up what they have right now, right here.
And the one question that I think we asked, but I don't think was specifically answered, had to do with women's reproductive health.
Yep.
All covered?
Yep.
Good. Is there anything that the three of you would like to add that we haven't asked about?
Well, I will only say thank you for giving me an opportunity to come all the way up here to talk to you about this. Please remain engaged. This is a long-term project. It is something that some of my colleagues have been fighting for decades. And so it is not, and the closer that you get to the end, the harder it is going to be. That's where it gets, you should know that when you see my face in your television, in black and white, grainy footage, with a slow close-up, talking about that this man wants to take your children and your taxes, then you'll know we'll be winning. But between now and then, we need you to be engaged. That's all I'd say. Ma'am?
Again, thank you so much to the League of Women Voters for putting this together, and we look forward to continuing our work together to get this across the finish line.
Thank you.
You got the last word, buddy.
I would just say thanks again to the League of Women Voters as well, and all of you for coming out tonight. I would add one, I'd call it an optimistic note. Yes, it is the long haul, but New York is a paradigm. If New York can pull this off, it would have, there's no question that California would follow suit. Then you have the two huge states doing it, and it would also benefit the national effort. So it's critical that we keep pushing in New York, because I think it can only have positive consequences.
Sorry, I'm adding on one more thing. So when I do PowerPoints, I always show a slide of a picture of an old fellow that nobody recognizes, and it's Tommy Douglas, who is the father of Canadian Medicare. And he is still voted most popular Canadian year after year, and he's been dead a while. People love Medicare. When in countries that have these programs, nobody's talking about taking them away, because once it is a right of the people, you're not going backwards. And that political legacy is on the table here in New York and in the country.
Thank you. And thank you very much. In closing, we would like to thank all of the workers and the League of Women Voters who were so good about helping with this forum and so diligent. We thank you to our timekeepers this evening, Phyllis Honig, who's our League of Women Voters and Putnam County Vice President. No, but it was good to know you were there. And to Dorothy Schmidt, a League supporter who has kindly offered to assist with the timekeeping tonight. We thank our guest speakers. We thank you, Deb Feynman of the Mahopac Public Library and her staff. Deb is right back there. We thank you to Cornell Cooperative Extension and 4-H Media Club, led by Joanne Riccaboni, and their voluntary service of videotaping tonight's forum. Comcast Cable's educational channel, and the League of Women Voters, and Bill Waldman. Where is Bill? Bill is actually a member of the League of Women Voters also. He's not.
He's not.
Wasn't he?
Yes, he is.
Yes, he is. Our league will be hosting an educational forum on June 20th on saving Putnam's lakes, rivers, and streams and our drinking water. It will be here at the Mahopac Library. And our 2019 Candidates Forum for Putnam County and town races will be held in September and October. You know, we had a program a couple weeks ago, or a month ago maybe, on how the voting will change in Putnam County. So hopefully we'll remind people at the Candidates Forums on all the differences that have come into play this year, where you're going to be able to vote a week early too. Respectively ask that you please show your appreciation by casting a donation into our Students Inside Albany Scholarship Jar. All donations are greatly appreciated. And we thank you all for coming out tonight. And it didn't storm yet. So